Everybody, welcome to Grand Rounds. Today we have Dr. Philip Payne with us. He is the founding director of the Institute for Informatics. He has a focus on clinical informatics, big data, machine learning, and optimizing the electronic health record to further our medical care. So without further ado, please welcome Dr. Payne.
Thank you. Right, so I was sharing with Vicki, and I will share with all of you. I'm excited to be here for two reasons this morning. One, I was glad to find the right location. I have not been to Grand Rounds in person for probably 3 years. So this morning on autopilot, I walked all the way over to Wool. You'll be glad to know it's still there. And the second anecdote I would share is a couple of years ago, the last time I gave Grand Rounds, it was an accidental Grand Rounds. One of my colleagues was meant to be speaking at Grand Rounds and got stuck in an Uber in sort of atypical traffic. And so Vicki looked at me and said, "Could you give a talk?" And so I gave Grand Rounds with about 2 minutes notice. So now that I found the right location, and I may have had a little bit more time to prepare, hopefully this will be a little bit smoother sailing. So as the title of the talk infers, what I want to talk about is this idea of building a learning health system, and in particular, the role of the electronic health record as a foundation for the learning health system. So we certainly spend a lot of time talking about the limitations of electronic health records, and they are numerous without a doubt. But in equal measure, there's a lot of opportunity that the EHR provides us with. And so this talk is a little bit more of a positive view on how we leverage our investment in the electronic health record to improve decision-making at the point of care and at the population level. I'll just include a few obligatory disclosures. I often make the joke when I put up my disclosures slide that if I'm giving a talk on one of the two coasts, everyone looks at me and says, "That's it." Whereas when I give a talk in the Midwest, everyone looks at me and they're very suspect. So I'll allow you to judge accordingly. So to begin with, and as I said, what I want to talk about is this idea of building and operating a learning health system. And there's been a tremendous amount of literature written about the learning health system. What is it? How do we build it? What are the changes that are needed to realize this model? And while there are really a lot of definitions out there, and I'll get in a moment to a definition that I like to use, I think the real sort of core of all of these discussions is how do we embed learning in everything we do in the clinical care environment so that the data that we collect for care delivery purposes is equally usable for research and innovation? And then importantly, how do we bring that learning back to the point of care? How do we close that evidence loop so it's not a unidirectional process? So certainly there's been some seminal reports from the Institute of Medicine. I cited that here. There has also been much discussion around how these learning health system constructs can be connected to create a network of learning health systems nationally. I would say that while this was an aspirational goal well over a decade ago from the Office of the National Coordinator for Health Information Technology, we have still not truly achieved this model of a network of learning health systems. So there's still opportunity there. And I think more recently, a lot of the conversation around learning health systems has focused on the role of big data. If we're producing more and more data, rather than just storing it in an electronic health record or in a data warehouse or on somebody's computer, how do we actually mobilize that data and make it actionable for decision-making purposes? But as I mentioned, I'm going to give you my preferred definition of a learning health system, which is really that it's a health system where we embed a set of behaviors so that every time we interact with the patient, it's an opportunity to learn and improve that patient's care, their family's care, and their community's care. And I want to emphasize that key point, that it's really a set of behaviors. While I'm a technologist at heart and I love new technology, and I spend a lot of time in my laboratory focusing on the role of big data in transforming biomedicine, I consider those two areas to be sort of derivatives of the core issue in building a learning health system, which is enabling a set of behaviors. So I'm going to keep coming back to that theme throughout this talk. What are the behaviors that allow us to learn every time we interact with the patient and bring that learning back in terms of decision making? And that actually leads to perhaps a little bit more technical way of thinking about that set of behaviors, which was proposed by a number of individuals, including Chuck Friedman. Chuck was at the original sort of point in which the learning health system construct was defined, the chief scientific officer at the Office of the National Coordinator. He's now at the University of Michigan leading the first ever Department of Learning Health Systems. And he defines this idea of a virtuous data to knowledge flow in which we actually instrument the environment where we deliver care. We analyze the data that results. We engage in research that produces new knowledge. We represent that knowledge in a way that allows it to be reusable in the right time, place, and format. And then we deliver it in that right time, place, and format and evaluate its impact on decision-making and outcomes. And then importantly, we identify how that cycle changes care delivery and outcomes, and then we repeat. And so this goes back to the idea of research not being sort of unidirectional from research to practice, but rather being this constant cycle, which we talk about a lot in sort of modern academic medicine. But imagine if that cycle is embedded as a set of behaviors at the point of care, because that's what we're really talking about today. Now I'll shift a little bit and talk more about the role of AI and digital transformation, because of course, as an informatician, I can't help myself. I think I'm legally obligated to talk about artificial intelligence in every talk. And artificial intelligence is the sort of scientific foundation of the field of biomedical informatics as a scientific discipline. As a field, it really came about in sort of at least its most contemporary version in the 1960s with a lot of formative research applying AI for decision-making, and it remains today a foundation of the field. And AI is really about how do we take the processes that human experts use to sort of ask and answer questions and allow them to function at a greater scale or at a faster pace than we would if we relied on the human brain. I often remind people that the human brain is very good at identifying patterns in messy and incomplete data. That is our sort of cognitive superpower. However, the human brain is also optimized for the storage and recall of only 7 plus or minus 2 items of information at any point in time. It's actually why phone numbers are the length that they are. So the reality is that the human brain is good at finding patterns, but it's not good at retaining large amounts of information simultaneously. So if we have very complex problems where we need to find patterns in large amounts of data simultaneously, what we want to do is teach computers to behave like human experts in terms of finding those patterns, but be able to do it at a greater scale or faster. And that's what AI is. Many of us think to ourselves, we're in this, golden era of AI where we have, all of these devices that are AI enabled. So how many people in this room have a voice assistant in their house? Do you have an Alexa device? I'm always afraid to say the word for fear that it's going to answer me in the room. So, the voice assistants appear to be very intelligent, right? They can tell you the weather, they can order you groceries, they can tell you what the current news is. The reality is they actually only exhibit a level of intelligence akin to a 4 or 5-year-old if you actually were to measure that objectively. But what they do is find answers very quickly. So they appear more intelligent than they are because they get to answers more quickly. And that's sort of the crux of AI, right? Because AI is only as good as the knowledge that we encode to make the AI able to answer those questions in the same way that human experts do. Which goes back to this issue of the role of AI in medicine, which is how do we use AI to enable our experts to find important patterns in increasingly large amounts of data more quickly or with greater scale. And this is very closely linked to this concept of digital transformation, which is if we have computers and networking technology and AI that's embedded in every part of our lives, like the voice assistants I just alluded to earlier, how do we change the way we live our lives, the way we do our work, the way we make decisions? That's what digital transformation is about. How do we change decision-making as a function of having these technologies at our fingertips? And that leads to sort of this fundamental theorem of biomedical informatics, which I really like, and I think it's really important to frame up the rest of this talk. And again, this is work by Chuck Friedman and colleagues. And this theorem postulates, I believe appropriately, that the role of AI and informatics more broadly is not to replace humans. It's rather that the combination of computers working with humans synergistically produces a better outcome than humans working alone. So back to my prior definition of AI and that role of pattern recognition and the intrinsic limitations of the human brain in terms of amounts of information as compared to strengths in terms of pattern recognition. I think this is very true in clinical decision-making, right? Human experts, physicians, are very good at decision-making because we teach clinicians to recognize patterns. That is the core of what we do. So if we can replicate that to draw the attention of those humans to critical data in this sort of increasingly voluminous sea of data, we have an opportunity to, in fact, improve the scale and accuracy of decision-making. So the takeaway is that AI in biomedicine is almost always about speed and scale, not about innate intelligence. Back to my comment earlier about voice assistants. So that leads us back to the learning health system. So if we acknowledge for a moment that there's intrinsic power to AI and the use of all this data that is at our fingertips, and we want to get to a point where those behaviors that make up a learning health system become sort of the norm, then we need sort of a roadmap. And I'm going to give you my 4 easy steps. This seems like it's almost too easy, and that's somewhat intentional. So the first is that we just have to instrument the care delivery environment. We have to be able to capture all of this data. That data may exist in the electronic health record, but it can also exist lots of other places: laboratory information systems, imaging, biomolecular phenotyping, such as sequencing or other functional genomic measures, not to mention behavioral instruments or the exposome and social determinants of health, and sort of all other data in between. So we need to capture all that data and get it sort of to a time and place and format where it's actually useful. Then, if we can do that, we need to make that data more accessible to people who are trying to either conduct research or make decisions, and provide them with the analytical tools to make that something that doesn't require sort of specialized technical experts, but rather becomes democratized and sort of part of the everyday life of clinicians, researchers, and educators. And then use technology to close the evidence cycle. Back to the idea of bringing that actionable knowledge back to the point of care. That could be something like we're familiar with today, clinical decision support, or it could be something we're not even envisioning today, depending on the technologies that we see on the horizon. And then lastly, and perhaps most importantly, we need to continuously measure, evaluate, and improve at a systems level. Not sort of in a microcosm, but rather we need to evaluate at a systems level to understand how interventions based on this continuous learning process change the dynamic system that is healthcare delivery. Now, a little bit of a detour, because I said that seems a little bit too easy, what I just gave you, right? 4 steps: collect data, analyze data, bring those learnings back to the point of care, and evaluate. Doesn't seem like it should be too hard. Well, it actually is extremely hard in healthcare, because healthcare is an example of what we call an ultra large scale system. Now, I could give a whole talk on this topic, but this is something that has been studied extensively in the engineering and in particular the computer science literature. And other examples of ultra large scale systems are air traffic control or energy infrastructure. These are big, distributed, complex, heterogeneous systems that actually have very high stakes in case of sort of error or sort of missed signals. And so what that means is that we have to design computational systems in this ultra large scale system environment to acknowledge the fact that it's constantly changing, that you're going to have to build these systems out of individual pieces. They're not going to be a single solution to all of your information needs, that failure is going to happen, and we need to actually gracefully sort of address failure. And importantly, that there will almost always be conflicting purposes and needs, right? So like what we need in healthcare for care delivery versus research versus sort of operations of a health system, while they are similar, are not always in alignment. And so these are features that exist in other ultra large scale systems, and they exist in healthcare. And like I said, this would be a much longer talk if we wanted to sort of explore this fully, but I would argue today that we take advantage of very little of the research that's been done in ultra large scale systems in terms of the design of systems that we use in healthcare today. In fact, we sort of pretend as though we are unique and there's nothing that we could learn from those other fields, and I would argue that that is incorrect. I think this is manifest in a couple of ways in terms of the challenges of building a learning health system, particularly one that is AI enabled. I just cherry picked a few examples of articles that exhibit sort of both the positives and negatives of what I'm talking about. So we know, for example, IBM Watson spent quite a bit of time telling us that if we just trust them and use their very expensive machine learning platform, we can solve all the problems in healthcare. And after quite some time of pouring billions of dollars into that, they in fact did not change healthcare, and now they actually just sold the entire IBM Watson Health unit to a private equity firm. So that's an example where the approach to the use of computation to build a learning health system emphasized data and computation too much, really thinking it more as an engineering problem, and didn't deal with the human factors, those behaviors that make up a learning health system. We also know that there are challenges around getting enough data to build these systems. Certainly Google has gotten a lot of bad press in terms of some of their relationships with major health systems to, as is sort of described in this headline, harvest data to train their artificial intelligence tools. This is very much a double-edged sword. AI only gets better if we have more data to train it. And at the same time, we need to maintain the privacy and confidentiality of the patients and communities that we serve while improving their care. And so somehow, back to the idea of conflicting goals in an ultra large scale system, we need to find that inflection point. And we probably haven't found that yet. And then lastly, I would be remiss if I didn't mention the fundamental issues around sort of bias in these healthcare AI systems. The reality is these systems are only as good as the data, again, that are used to train them. And if those data are biased, then the behavior of the algorithms will be biased. That could be racial or ethnic or otherwise demographic biases. They could be geographic biases, biases in terms of the behaviors of providers and patients in a given population, or some mixture of all. And the reality is right now, we're not even good at measuring these biases, let alone adjusting for them. So there's a huge volume of work to be done just to understand the impact of bias on the design of these algorithms. And it's quite dangerous if we do not, because we can arrive at erroneous conclusions. So that leads me to sort of the core of the talk, which is what I'm going to describe as 4 critical questions that I think all of us need to ask and answer when we're seeking to build and operate a learning health system. And by that, I mean those behaviors that are enabled by AI and digital transformation. And in really sort of a sequential order of importance, it begins with, are we even trying to solve the right tasks using these technologies and capabilities? If it is the right task, do we have the right data? If we have the right task and data, do we know what the evidence standard is to say that that intervention is appropriate, efficacious, safe, and provides value and positive impact? And then if we can overcome those 3 hurdles, can we actually integrate that behavior and those technologies back into the care delivery process in a way that enables that fundamental theorem I talked about before, where humans and computers working together are superior to humans or computers alone? So let's start with the first question. When we seek to undertake a project to implement some component of a learning health system, are we selecting the right task? Is this something that's even appropriate for a learning health system intervention? So I'm going to take a little detour here and explain sort of how I, as an informatician, would think about this. So the field of informatics is really at its core, as I mentioned earlier, a field that is concerned with using data to improve decision-making. And that means we need to take data and provide context to it, right? And that's what we would call information. And then deliver that information in the right time, place, and format so that it can actually be used for decision-making. And that's knowledge or actionable knowledge. And there's an entire body of research and methodology that underlies our ability to translate data into information and knowledge. Raw data isn't very useful by itself. It's only as good as the context that we wrap around it, which can include our findings about that data, its origins, if that's going to be used for clinical decision-making, do we even know who needs to act upon that data and that finding if we have something of value? And then knowledge is how we put that all together and actually implement a intervention based upon that information. And this is a virtuous cycle that improves over time. But the reality is, if we're going to undertake a computationally enabled task to build a learning health system, we need to be able to ask the question, do we have the data? And we'll get to that in a moment. And can we capture that context to render that data as information? And then do we know enough about the problem space that we can design that intervention that turns that information into actionable knowledge? And if we really can't see the path to answer those 3 questions to sort of enable this data to information and knowledge workflow that I have illustrated here, it's unlikely that the task that we're trying to solve for is one that's appropriate. So let me be very concrete. In my lab, when students come to me and say, I want to do a machine learning project to predict an outcome in disease X, the first question I ask them is, if we had a predictive model for that disease, what would change? What would you do with that result? Because if we don't understand sort of the driving problem in a way that we can foresee an intervention based on that model, then it's unlikely that model is going to result in a change in care delivery. And then we have to ask, are we doing this because it's academically interesting, or are we doing this because it's going to change outcomes for our patients? So that's a fundamental question that one would have to ask before you could decide if the task is appropriate or not. And I'll give you some examples of that in a moment. So this is actually, just to be more concrete, a really great set of projects. I'll come back to this a couple of times, led by Drew Michelson and a number of other sort of key faculty in critical care, as well as anesthesiology and the Institute for Informatics, where we've been exploring dimensions of how we can predict and better understand the onset of sepsis in the inpatient setting. Now, the first thing that we did was ask the question, is this a task that we should undertake because there's a gap in knowledge? So rather than starting with building a new predictive model, we actually went and looked at all of the various mortality sort of risk scoring metrics that could be used for these patients that may develop sepsis in the hospital. And we asked two questions. One, does the data actually exist in the EHR to calculate these scores? And number two, if we do have enough data to calculate these scores, is the outcome something that's useful for enabling clinical decision-making? Does it actually predict outcomes that we've seen retrospectively in our population, right? Are the scores useful? Now, I'll give you sort of a spoiler. I have a pet peeve around a lot of risk scoring instruments because they tend to be built using retrospective data that's highly curated and often include sort of administrative and claims data that doesn't exist during the clinical encounter. So a lot of these risk scoring instruments perform very well in a research study, but they're not particularly useful in clinical care because we can't calculate them when the patient's in the hospital. And so if we're trying to change our decision-making around these patients that may develop sepsis, we need models that work when the patient's in the hospital with the raw, messy, incomplete data that comes out of the EHR. So I've included a quote here, but the takeaway is actually one of the first things that we learned in the area of sepsis was that the vast majority of these mortality prediction instruments perform very poorly in terms of the availability of data in the EHR, as well as their ability to predict outcomes for patients. So this would lead us to believe that there's a gap in knowledge. Back to, is this the right task? Should we explore sepsis? I would argue the answer is yes, because we have a set of risk scoring metrics that work very well retrospectively in a research setting, but do not work well prospectively for clinical decision-making. Not dissimilar, another project here in a completely different disease space, in Alzheimer's disease, we actually looked at the types of data that people use in reported studies to anticipate outcomes for patients with Alzheimer's-related dementia. And the idea here is, could we predict who's going to have more aggressive versus less aggressive disease? And if so, do those data exist, again, in the EHR or other available resources? And are we using the right data to be able to ask and answer those questions? And one of the really interesting things that you see here is that in the literature, there are certain types of data like laboratory data or, for example, basic cognitive assessments that are used frequently. However, genetic data, as well as to some extent neuroimaging data that we know scientifically may be far more useful in predicting outcomes in AD patients are rarely reported on in comparison to those data sets. So again, this is a study that actually showed the mismatch between our scientific understanding of the disease, the available data, and the way in which predictive models were being built. And that leads to the conclusion that there's a gap in knowledge, and therefore the task is appropriate for an AI-driven intervention. And yet one more example here in the case of looking at medication outcomes and adverse events, and this is another project with Fuhai Li and colleagues in the Institute for Informatics. We actually looked at sort of adverse events that were reported in conjunction with opioid use in the inpatient setting, and whether or not there were outcomes that were not anticipated, adverse outcomes, as a function of polypharmacy, multiple drugs being administered to these patients, and then conditions that are not included in sort of known adverse outcomes with patients receiving opioids. And the takeaway actually is there's a lot. So this is another example. These charts are a little bit hard to read here in these visuals, but the takeaway is there is a broad range of cardiovascular, neurological, and other clinical sort of adverse events associated with opioid use that are not reported in the literature, that are not reported in the FDA package inserts, but absolutely are occurring on a regular basis when these patients are being prescribed opioids alongside other drugs in the inpatient setting. And so again, an example where predictive models that could anticipate these adverse outcomes would be useful. So this is not the most glamorous part of the research process, right? This is just empirically, is there a gap in knowledge and does the data exist? Which leads to not only does the data exist, but is it the right data in order to ask and answer these questions? So this is one of my favorite examples of why using data from the electronic health record is so hard. So let's say that we were going to ask a question. Did patients, I'm going to use my opioid example again, did patients receiving an opioid also receive other drugs? And if so, did they have a higher probability of an adverse cardiovascular outcome? Well, how do we know if a patient received a medication? There's actually no specific singular measure in the EHR that says a patient received a medication. There's order entry data that tells us about the intent to give the patient a medication. There may be pharmacy data that tells us that the medication has been dispensed for administration to the patient. There could be a medication administration record that says that a care provider was at the bedside or otherwise was intending, again, to act upon that order with that available drug. And there may be other medication reconciliation data. Not a single one of those pieces of data is a direct measure of the patient receiving medication. They're all surrogates. So if we're going to ask this question, we have to decide, are we going to trust one of these or a combination of these measures, right? Create a synthetic variable that's sort of an aggregate of these. And importantly, if we do it, how do other people do it? Because you can get different numerators and denominators with even the most simple questions, depending on how you mix and match these different measures that are surrogates of the actual event of interest based upon what's in the EHR. And that's a relatively simple question, right? Did a patient receive a medication? Imagine if we want to do this with much more complex data. So this is an example of a paper that a number of us participated in, including Dr. Wilcox, who's in the room today, where we were exploring sort of the challenges that I just sort of tried to illustrate a moment ago around taking raw data from an EHR and trying to use that raw data to produce analytically useful data sets. And in this case, this is looking at a set of diagnostic codes that are suggestive in this particular scenario of type 2 diabetes in two different health systems with two different EHRs and the overlaps between those codes. Now, clinically speaking, if you were to look at these codes, these are things that we expect to co-occur for patients with type 2 diabetes. But you can quickly ascertain that the overlap in these codes, if we're going to create sort of a surrogate from multiple codes, back to my diagram I just gave you, is dramatically different between just two hospitals. Now, what if I want to do this with a dozen hospitals or 100 hospitals? And, you know, while it's not the sort of center point of this talk, we have a lot of experience from the COVID-19 pandemic trying to combine data from many different health systems on the order of, you know, between 75 to 100 major health systems in the case of a large initiative that was launched by NCATS at NIH. And the takeaway is it's exceptionally hard. We're still working on trying to harmonize that data. And quite honestly, it's taken so long to harmonize that data, one has to ask the question, is it even useful anymore given where we're at in the pandemic? So the human process of harmonizing data because of these vast differences is a major limiting step in saying, do we have data that's fit for purpose for analysis? I'd also point out that if you try to scale this to sort of the public health domain, this gets even more complicated because of the multitude of both technical and political issues that prevail. And this is actually another publication where we actually looked at the current state of data sharing around COVID-19 and then sort of an aspirational state where that data sharing would be useful. And the takeaway is during COVID-19, while we shared lots of data, everyone did it differently. Everyone had different ways of defining that data, different ways of harmonizing that data, different impacts as a function of policy decisions and access controls. And the result is that nobody had a complete data set to understand what was going on in COVID-19 because the political and technical dynamics were far too complicated. Back to that sort of ultra large scale system argument. Now, all is not lost. As many of you probably know, here at WashU, we happen to be very invested in the area of synthetic data. It's sort of a new set of technologies that, again, use artificial intelligence to produce synthetic derivatives of our clinical data that look and feel like the real data, where we can address a lot of quality issues, harmonization, et cetera, and we can do so in a way that is both private and confidential for our patients and populations. So this is sort of the cheat sheet version of how it works with the platform that we happen to work with here at WashU called MD Clone, which is that if you imagine some set of features that define a population of patients, these could be laboratory measures, demographics, et cetera. For every patient, they have a measurement for each feature that sits sort of in a distribution. And you can think of it as sort of a density of all the patients in your population for each feature. So a patient's record becomes a vector that passes through this, right, with each of their individual measurements. And with the synthetic data tool, what we can do is create new vectors that satisfy the covariance across measures and the density for each feature space, but don't share any common data with the source patient data. So that means statistically, they look and feel like the real data, but practically speaking, you cannot re-identify a patient from that data. And that's really powerful because now this clinical data becomes non-human subjects data. We can share it, we can analyze it, and quite honestly, we can also do a lot more analysis on that data to understand quality and completeness along the way. So this is an example of a study, and actually, again, Dr. Foraker and Dr. Wilcox were key leaders in this, that actually looked at the use of exactly this type of technology, in this case, in the context of that large COVID data set I mentioned earlier from NCATS, and showed quite definitively in what arguably is the largest synthetic data set that's ever been produced, that you can conduct a variety of statistical and machine learning analyses using synthetic data, and they will produce identical results to what would have happened if you'd done those same analyses using the source data. So that means we can replicate analyses like we would conduct with source data, but we can protect patient privacy and confidentiality. And using these modern AI techniques along the way, we can also address sort of data quality, completeness, and harmonization issues. So this is a powerful tool for us, right? This is data that can be accessed in minutes and mouse clicks as opposed to hours or weeks or months with a more traditional approach. And that fundamentally changes the way that we think about analyses in sort of this AI-enabled learning health system. So now we've answered those two questions. What about the evidence standards? How do we know if these interventions that are informed by these analyses are actually useful? Do they have sort of the anticipated impact? How do they affect safety, quality, value, outcomes, all of the above? So I'm going to just engage in a little bit of clinical trials 101 for a moment. I think we all know that the randomized controlled trial is sort of the gold standard for study design. And there's a lot of variations on this theme, but the basic concept is if you take patients in a population and you randomize them into an intervention and control arm, and then one group gets the intervention of interest, one does not, or gets the standard of care, and then we compare results, we can generally come up with a relatively unbiased conclusion about the relative efficacy, safety, or sort of performance of the intervention. And by its very design, the RCT is meant to sort of allow for this balanced view of the intervention of interest, and ideally reduce bias. And remember, I talked about bias as a major issue before. However, I'm going to explain to you why this is a real issue in the learning health system, where we use lots of data to understand what's going on with our patients. So if I'm looking how the average patient responds, let's say the average patient with type 2 diabetes, and I have a condition or an outcome with high prevalence, there is a good chance that if I randomize patients into an intervention and control arm, that I'll get relatively balanced samples, right? It's just sort of a statistical sort of function of the population. But if I'm now going to look at each patient as an individual and use all of that rich data to make decisions that are very unique to the patient in front of me right now, that prevalence is likely to be very low. And now I have a situation like what you see on the right with low prevalence, where I might only have one or two patients that look or feel like the patient in front of me today that I've designed my intervention for. And if I randomize into intervention and control arms, I can create extremely imbalanced populations for my study. And therefore, I will not arrive at a useful and unbiased outcome in terms of my study design. So if we have more data and we can use that data to treat patients as being sort of unique individuals and make decisions at that unique individual level, all of a sudden, the sort of bias reduction that sort of traditional RCT sort of randomization provides for us becomes highly problematic. However, using sort of pragmatic studies where we leverage the data in the electronic health record and where we use sort of adaptive methods that sort of balance the groups based upon the features of interest, you can overcome that bias. So this is an example of a study that we conducted with the NF1 Center here at WashU, looking at clinical features associated with NF1. If you're not familiar, this is a rare genetic disease, relatively easily diagnosed. However, has a variety of subphenotypes spanning a spectrum from ADHD to optic pathway gliomas to scoliosis. And we are very bad at predicting which one of those subphenotypes kids will experience. And therefore, clinical management is challenged in terms of being able to identify especially the most deleterious subphenotypes early for these children. And so the question was, rather than sort of, treating all the individuals as sort of the average patient with NF1, we asked the question, could we predict outcomes for these patients? And the takeaway actually for optic pathway glioma, ADHD, and actually plexiform neurofibromas, which are nerve sheath tumors, is that we can actually use data from the EHR, behavioral instruments, and imaging. And we can predict with high degrees of accuracy, as you can see here, which patients will actually exhibit those subphenotypes and identify them early and often after their initial diagnosis. But the key is this is sort of a pragmatic study that was done retrospectively with adaptive balancing across sort of those study populations entirely based on EHR data. And so I think this speaks to the future of we need more data and we need to use these adaptive study designs both retrospectively and prospectively if we're going to overcome these potential biases. Back to our favorite topic of sepsis, this is another example actually of doing the same type of adaptive and retrospective study, in this case looking at automation of those sepsis identification criteria that have been published and how they actually have performed. And what you can see here is that there's high degrees of heterogeneity in the populations that develop sepsis during an inpatient stay, and therefore we found that sort of there was some correlation in a subset of those populations around conventional risk measures like the Sears criteria for identifying those patients who are becoming septic, but it was not universal. And so the takeaway there is it actually speaks to subphenotyping in the sepsis population, which we tend to treat kind of as like a big mass, like people with and without sepsis. And this study would actually argue for a more nuanced view, again, with this pragmatic, adaptive, retrospective look at the data in the EHR. And then lastly, if we've overcome the question, do we have the right task, the right data, and we are able to ascertain sort of what the evidence standard is that we should employ, and therefore we produce evidence that we think is actionable, back to that data to information and knowledge lifecycle, how do we bring that back to the point of care? How do we actually use that to influence decision-making? So there's this idea in cognitive psychology of what's referred to as the intermediate effect that impacts technology adoption. So let's use an EHR as the most sort of large-scale example of this. There's some level of performance, whether that's sort of speed or accuracy of decision-making that exists before we introduce a new technology. And then usually when we introduce a new technology, performance decreases. It often sort of sits at sort of what is affectionately labeled on this diagram as the trough of despair for a period of time, in which performance appears to be not only low, but continuing to be low. And then at some point, we begin to increase our performance and we get ideally to a higher level of performance than where we started. So it's almost inevitable if we introduce a new technology, say a clinical decision support intervention or an EHR, that things are going to get worse before they get better. That's the takeaway of this diagram. And I would tell you that we often don't plan for this when we think about introducing these new technologies, but it's a proven fact. And it has to do with the fact that experts make decisions, back to what I said earlier, through a process of pattern recognition. And if we introduce new technologies that influence how we collect and think about data, we basically are going to disrupt that pattern recognition task and require experts to be able to rewire their thought process, what we call personal constructs, in order to be able to navigate that new technology and get back to their previous level, if not an improved level of performance. And so that means we actually have to think about what we do during that trough of despair. And I often tell people, when we introduce a new technology in medicine, we often think about the initial decline. We're like, oh, we need to reduce schedules, or we need to provide more training or something like that. But then we assume that like something magic happens after a few weeks and everything's going to be great again. And then we take all those resources away. And people often get stuck in that trough of despair. And I would argue that's why a lot of technology deployment projects fail. Because if we were really thoughtful about this, we would put even more resources in to supporting our care providers or other decision makers in that trough of despair to be able to push us through that process faster and get to increased performance. And so I'm sharing this with you because we need to study these phenomena and understand them when we introduce these new technologies, these new digital interventions in the healthcare environment, lest we get stuck in the trough of despair and never actually get to that higher level of performance. And the reality is we actually have really good tools to do that were developed at effectively the dawn of the Industrial Revolution, which are time and motion studies. So we can go into the clinic today with time and motion study tools and see how people use technology, how they leverage that technology to inform decision-making, what other resources they use, and how those resources further influence sort of performance, and understand that before we introduce a new technology so that when we do, we're doing it in a way that actually accommodates or is appropriate given our understanding of the real-world workflow. So when's the last time when a new technology was being deployed in our hospital that someone came and shadowed you in the clinic before the technology was deployed? Anyone? No, we don't do that. We know that that works, but we don't do it. So the reality is we have great tools and great methods today to be able to understand workflow and design the deployment of these technology interventions to be superior than current state of the art, but we do not use those tools. So this is back to that sort of ultra large scale system argument, a big missed opportunity. I guarantee you in air traffic control or electrical infrastructure, nobody deploys a new control system without studying the human factors of the existing system first. Why don't we do the same thing in healthcare? So this, in my opinion, is one of our biggest missed opportunities. Now, beyond that, there's also issues around sort of plausibility and believability of artificial intelligence interventions. So I've talked a lot about the power of AI, but one of the issues is that we know there needs to be an explanatory mechanism. People need to trust and understand the output of the AI when they're making complex decisions. So this is an example of a study, again, this is in the Alzheimer's domain, looking at what we call self-explaining neural networks. So neural networks, one of the most common tools that we use for sort of machine learning and AI. And one of the things that we've learned is that if you actually take the performance of the neural network in a population, and then we plot that against the performance of humans or sort of a gold standard in that same population, and we can show that those distributions converge, that simple visual is really, really important in terms of creating trust in the AI. And that's actually the examples you see here, right? Here's how real patients perform. Here's how the AI predicts they're going to perform. How different or similar are those distributions? And especially across multiple features that may influence the performance of our neural network. This is a very simple concept. Show people the performance of the neural network, compare it to the real world, and if they're sufficiently similar, the likelihood is that individuals consuming the output of the neural network will have a greater degree of trust and understand how the neural network performs based upon the features that are being fed into it. And then I would also just say, we can also use this approach in a very different way. We can look at it as a sort of study of the people using the technology. So recently, we have been examining how we could use log files from electronic health records to be able to identify individuals that may be suffering from burnout. And this is work that Thomas Kahn-Paul and Brad Effenoff and a number of other key individuals have helped to lead. And now we have a collaborative project that's funded by the National Library of Medicine with UCSF to expand these analyses. But we're looking at the log files and trying to find out who's at risk of burnout and is that affecting clinical decision-making? And we can find early warning signs of that based upon the behavior of providers interacting with the EHR. So that is a personalized signature for the provider, not the patient, where we might be able to trigger an intervention, which is, hey, you might want to take a moment because the likelihood that you are going to make an error in this order or this decision-making process is higher because you appear to be engaging in sort of an interaction with the EHR that is suboptimal. Now that's, a little bit of a scary prospect, right? The idea now the EHR is going to give you behavioral health advice. But the reality is that the data is very clear that we can find these signals in the log files. So this is sort of the other side of the equation, that we could actually use the EHR to be able to better intervene and support care providers in a very high intensity environment. So just a few final thoughts, and then we'll have some time for questions. I would start with sort of what I want to describe as sort of a balanced view of the learning health system, because I know there's a lot of hyperbole, a lot of enthusiasm. Everyone's super excited about AI, big data. But I would argue that the learning health system as a framework for informing our behaviors has a lot of promise. and especially a lot of promise in terms of improving safety, outcomes, quality, and value of care. And not just at the individual, at the population level. But, and I hope I've sort of made the case today, things like inconsistent data quality, limited evidence to help us evaluate the performance of these tools, not to mention sort of all of the issues around integration of these technologies back at the point of care, as I alluded to. These are all issues that threaten our ability to realize that promise. And I think we need to be very serious about conducting the research that allows us to answer those questions. And whether or not this learning health system construct is going to make care better, I would say is not proven yet. We have not necessarily shown that using all this technology and sort of thinking about continuous learning processes will definitively improve all aspects of care. I think we have examples where it's been proven sort of in very specific targeted domains, but at a systems level, I don't believe we've gotten to that bar. And that's why there's a lot of work, maybe it's job security for all of us, to continue doing critical research, both pragmatically at the point of care and in the laboratory and in clinical studies in order to understand all these questions that I put out there. And I'd also put out as sort of a sidebar, many people say, why even worry about this in the academic setting? Isn't industry going to solve all these problems? Industry brings a lot of capability in terms of computation, AI, data engineering. But industry, and back to the IBM story I shared at the outset, will not be able to replace the expertise and capabilities that exist in the health system environment to study and understand the impact of these interventions, because that requires real patients, real driving biological and clinical problems, and real clinical expertise. And so it's really only when industry and academia and health systems work together that we can tackle all of these problems. And then just lastly, I guess a challenge to all of you and maybe a homework assignment. If you've not read this book by Donald Stokes called Pasteur's Quadrant, I recommend this to every audience I talk to. This is a really important sort of what I would describe as sort of philosophy of science publication. And I think it speaks to the work that needs to be done today and in the future to build a learning health system, which is this idea that we cannot make this artificial barrier between basic research and applied research. And think of it as sort of a unidirectional relationship between the two. That's actually preventing us from being able to move the needle on the critical questions I just alluded to. But rather, what we need to engage in and what is described here in Pasteur's Quadrant, using the work of Louis Pasteur as sort of an exemplar, is use-inspired basic research, where the very same people that are developing new theories and methods are applying them in the real world. And that's actually a call to action for, in particular, our clinician scientists, because that is the critical role in this environment, building a learning health system, that the clinician scientist plays. And so I think this idea is sort of a unidirectional flow where basic scientists sort of are isolated from like the practical real world of clinical care and operations and vice versa is a major barrier to all of the opportunities that I just talked about before. So this is a very short book, by the way. Everyone could read this like in a weekend. But I think it's a very interesting way of thinking about the science. Good news. Here's lots of QR codes for you. Good luck with all of those. And then the one that I provided, which is in the upper left corner, and there's also a URL, there's a version of these slides that you can download if you want a copy. So with that, I will leave these up here so that I don't mess up your QR codes.
Philip, thanks so much for that talk. Do we have any questions quickly from the audience or?
Thank you for the talk today. How do we balance the goal of providing more data in the healthcare environment to the researchers with the goal of limiting the cost of care to patients and avoiding the practices of defensive medicine? Certainly, we don't want to get a brain MRI on anyone as soon as they walk into the hospital.
Yeah, so I'm going to give sort of a twofold answer to that, and it's probably not going to be comprehensive or entirely satisfactory. So spoiler alert. So the first thing I would say is that we need to be more precise in terms of what data we collect. And so that impacts both how we practice medicine and how we conduct research. So if we really embed research, right, in the daily practice of medicine, we would say, we don't need to capture every piece of data because we'll hypothetically answer a question in the future. We could say, like, here are the 10 or 15 really high value pieces of data that we need today for this patient population. And we don't really do that, right? I mean, let's be honest, the way we design the EHR and decide what's going to be structured and what's not, and sort of what's going to be a required field and what's not, there's no consideration of the secondary use or research use of the data by and large in that conversation. So in this set of behaviors, we would have to do that. And I'll just share anecdotally, in my experience, every time I work on a registry project with a clinical group, and I'll say, what data do you think is really important? I think Adam will back me up on this. And people will give you like a list of like 200 variables, like we need to collect all of this. And then we'll work with them and decide what's going to work in workflow and the actual research projects, and it'll end up being like 15. So we have to resist the idea that we have to collect every piece of data, right? And accept the fact that with sort of longitudinal electronic health records, worst case scenario, we could go back and get more data if we need to. And then to your second point around sort of, you know, how do we make sure that, you know, I'm going to sort of paraphrase, this generates some value, right, in sort of the broader system. That actually means that we have to connect the data that is sort of relevant to value to us and to patients with the other clinical data and analyze that in aggregate. And I will tell you, we create a lot of artificial barriers between financial and patient reported outcome and satisfaction data and what's in the EHR. And back to that sort of system science, ultra large scale system construct, we have to start breaking down those barriers. There's no scenario where care gets better and less expensive and our providers are more productive and patients are more satisfied unless we actually combine all this data. It's impossible, right? We will not ask and answer those questions unless we put that data together. And so we actually have a lot of self-inflicted wounds today in terms of all the firewalls and regulatory frameworks that prevent us from being able to do that. So hopefully that answers part of your question. I know it's not the entirety of it, but.
Stephanie, are there any questions on the chat? Okay. So Philip, I have a question. You mentioned the risk of burnout.
Yes.
With using electronic medical records and the predictors or triggers you could identify. So I might guess that those might be, you know, who's on the electronic medical record in the middle of the night, on the weekends, who's got, you know, billions of things in their inbox or delayed, you know, sign-offs. Are there data that if you get those folks champions and really help them improve their efficiency, that you can improve their efficiency and the burnout risk goes down?
So I mentioned earlier that Thomas Conopolo is leading this project, and now it's also funded with UCSF with Julia Adler-Milstein's group there. And that's exactly what we're trying to look at. I think what's interesting is it's not just timing and sort of, you know, who has a lot of messages. There's also things like behavioral indicators, right? So there are efficient pathways to navigate through the EHR from one task to another. And I'm going to ignore the fact that the design of the EHR is intrinsically inefficient in a lot of scenarios. And then there are inefficient pathways. And so one of the things you can identify is when people become, you know, sort of cognitively overloaded as a function of burnout, they may actually engage in less efficient navigation pathways. And that's another example of signal, right? So basically people are, I'm going to paraphrase, doing things the hard way rather than the easy way because they're cognitively overloaded. And we do have some preliminary data that tells us that you intervene with, you know, sort of whether that's coaching or sort of a timeout or sort of other sort of relatively simple nudges. If you think about from a behavioral economic standpoint, you can sort of short circuit that sort of cycle of increased burnout. So I think there's an opportunity there. I think the real problem, right, is, and I'm going to say this from a non-clinician standpoint, so everyone can yell at me if you don't like this, is, you know, there's a certain degree of stigma, right, around sort of acknowledging burnout and sort of taking steps like what I'm describing. So one of the things we need to do is sort of destigmatize that, where that becomes part of sort of practice, and it's not something that people, you know, feel is somehow deleterious to them from a sort of reputational career standpoint. Because the reality is that our providers are under increased load, the cognitive complexity is very high, the EHR is very complicated, the patients are more complicated. It's inevitable that we create burnout. And so the question is, how do we stop that?
So I appreciate in your answer, especially previous answer that you gave, we need to avoid the temptation to think we need to get every piece of data. Because when you first listen to these instrument the healthcare system, I was worried that you were going to make the argument that we need more data. That argument has been made before by meaningful use. $35 billion later as a low estimate. That much the meaningful use system in terms of ripping and replacing and installing the EHR, all we've ended up with is a lot of really frustrated physicians
So 2 questions. Number 1, do you feel that right now we actually have enough data to effectively instrument and enable the learning healthcare system sufficiently to get improvement? And if yes, and I hope the answer is yes, because I don't think we can get there otherwise. What is the most important thing that we need to do now, given that the data exists, but we're not leveraging it in order to make that?
Yeah, that's a great question, Adam. So I would say we have more data than we know what to do with today. It's not always easy, right? Some data is embedded in narrative text or in images, et cetera, where it's a little harder to compute on, but I think we are getting better at it. We use such a fraction of the data in the EHR today, and everyone always says, let's collect more data. Let's, do another study, build another registry. I would hope that some of the examples that I gave where we're just dealing with raw, messy, real world data, give people a glimpse that you can do really high quality research and improve care with that real world data. Because as I've said to people, there's not going to be a graduate student standing behind every physician curating and cleaning up their data that comes out of the EHR. So back to the idea that we need interventions that are actionable. We need to deal with this is how humans produce data in healthcare. And I think we have way more data than we know what to do with today. So my answer is yes, there's a ton of data and we need to be mercilessly pragmatic and use what we have before we start asking people to collect more data. If anything, we should ask for less. Yeah.
Mark, you had a question?
So.
Yep.
Finding, discovering the problems. To the point that there was almost a failure. I was wondering, did your work on this primarily focused on the outpatient setting, or has it also been done on inpatient positions?
So are you talking about the burnout work?
Yes.
So the burnout work right now has been focusing on inpatient clinicians, but I will tell you that we're very interested in looking at it in the outpatient setting. I'll also share with you it's very hard in our environment because we have far less data about ambulatory primary care practice because of the nature of sort of our system. And so we have been talking about trying to build a bigger consortium to get more of that data. However, some of the things that we're discovering, you mentioned chats, right? So additional communication channels, secure chat, inbox, et cetera. There's a high correlation in our preliminary data, not surprisingly, with burnout. And one of the things I would say back to the digital transformation side is how much of what we're doing right now could we provide better tools to support our patients' information needs without having to have a provider answer every question. So one of the questions is, are there sort of automated triage mechanisms to get people closer to an answer so that we reduce sort of what I consider to be low value interactions? I think that's a real question for us to tackle. And I know it's a little scary, right? Because we're really talking about do we use a chat bot for some of the things that people use? But I'll share with you, just as an example, during the height of COVID, when we needed to screen hundreds of thousands of patients as to what bucket they went into for vaccination and how we got them scheduled, we did that all with a chatbot, and it worked. And that was like a trial by fire. So I think there's opportunity there.
Philip, thank you.
Like 4,000 QR codes.